The thyroid gland develops in two forms. One is the follicular region, which starts and descends from the base of tongue, and then from there it descends down to the thyroid gland. It spreads out outwards where it is joined by the parafollicular region. So abnormalities in terms of the thyroid development or thyroid descent will result in a very small or absent thyroid, a term which is known as thyroid dysgenesis. The most common cause of thyroid dysgenesis is in fact the ectopic thyroid, in that the thyroid is not in the normal position near the neck, but somewhere between the foramen cecum and the base of tongue, that is between the thyroid, and this could be a small swelling there. Most children who have an ectopic thyroid or who have thyroid dysgenesis would require a lifelong treatment. Another important cause of congenital hypothyroidism is the problems in thyroid hormone synthesis or dysharmonogenesis. Thyroid is an iodine concentrator which takes the iodine from the blood, converts into through multiple enzymatic processes, combines it with the amino acid tyrosine to produce T4 and T3. Defects in any of these enzymes can also result in the development of congenital hypothyroidism. The term for that is dysharmonogenesis, problems in hormone synthesis of the thyroid hormone. Importantly, in this condition, the pituitary is going to try to increase the thyroid hormone production, so it is going to stimulate the thyroid gland, resulting in the development of goiter. So a child who has congenital hypothyroidism and thyroid swelling, we start thinking that the problem is not at the level of thyroid formation, but at the thyroid hormone synthesis or dysharmonogenesis. Vast majority of children who have congenital hypothyroidism have a permanent form. They would require long-term treatment. However, a subset of individuals, including those who have iodine deficiency or excess, those who are born premature, and where the maternal TSH receptor blocking antibody crosses the placenta, may have a transient hypothyroidism. The thyroid stimulating hormone receptor blocking antibody present in the mother may pass the placenta, suppress the TSH action, resulting in congenital hypothyroidism. Now, while it is important to start treatment in these individuals at an early age, we should be very cautious that they may not need treatment for a long time and may have a transient hypothyroidism. In this scenario, the best approach will be to follow the thyroid functions and adjust the dose, and often we may be able to stop or decrease the dose by around 2 to 3 months. Importantly, TSH receptor blocking antibody in the mother causing congenital hypothyroidism is associated with a decreased uptake of thyroid nuclear scan, while the ultrasound will show a normal thyroid gland. One group of individuals where the thyroid functions may be abnormal in the initial phase and may not need treatment is the preterm babies. Thyroid hormone levels are very low in the fetus. They start being produced at 15 weeks. They gradually build up, and only after 30 to 32 weeks the levels really start building up. So if the child is born preterm around 28 weeks of gestation, the thyroid hormones will be low. And in that scenario, we should not start treatment, and often this problem is confounded. Often this problem is increased because of infection, because of illness, and a number of medications. So preterm babies who do not have features of hypothyroidism but have unusual thyroid function results do not need treatment in most scenarios, and they will improve overall.